Welcome everyone, wherever you may be around the world, to the 4th World Sepsis Congress, One Global Health Threat, Sepsis Pandemics and Antimicrobial Resistance. And for those of you who were able to turn in, we had an inspiring opening to the Congress. And this session, though, the second session, we'll be discussing health, economic, and the human burden of infections and pandemics. We know that one person, shockingly, every 3 seconds dies of sepsis around the world, and 75% of the survivors suffer long-term effects. The poor are affected more than anybody else. But in the midst of the tragedy of COVID-19 lies an opportunity, and the opportunity is to build forward better. If we're able to prevent, detect, and respond to sepsis, the interesting thing is we create a platform that strengthens the entire health system to address whether it's infectious diseases or non-communicable diseases. And today we have a stellar panel to address just that. So what I'm going to do is I'm going to introduce the panelists. And what we'll do is each panelist will speak for about 10 minutes, 3 minutes of questions. So get your questions ready and put the questions in the question box. And then each panelist will speak, and then we'll go from one panelist to the next. So the panelists on this particular panel are as follows in the order in which they'll be speaking. Dr. Carolin Fleischmann-Struzek, she is a physician scientist from Jena University in Germany. She's a co-author of the first WHO report on sepsis epidemiology, and she's been a leader in estimating the burden of sepsis globally. Next, the next session will be on accelerating progress for universal health coverage in South Asia and COVID-19. Dr. Syed Masud Ahmed is at Dhaka University in Bangladesh. He was ranked the second highest Bangladeshi science for social scientists and the humanities. He is currently leading research in advocacy, capacity building, and ways to improve health systems. Our next speaker will be Dr. Tim Buchman. Dr. Buchman will be speaking on health, economic, and the burden of sepsis. Dr. Buchman is at Emory University in Atlanta, Georgia. He is a professor of surgery and a virologist, the past president of the Shock Society, editor-in-chief of the Critical Care Medicine, and he's been a leader in using AI to predict which patients would actually become septic in an ICU. Then Dr. Roy Small from the UNDP, who is a lawyer, he will be speaking on universal health coverage for sustainable development. He has worked with UNDP to promote health systems around the world and to advance actions to address non-communicable diseases, tobacco, and other challenges. And finally, the last speaker will be Mr. Rob Yates. He's at Chatham House in the United Kingdom. Mr. Yates will talk about how universal health coverage can climb up the political ladder. He's a political health economist who will be speaking on universal health coverage and health financing. And he's an expert in that. And he's been also an advisor to the Elders Group and other political leaders around the world. So with that, it's my great pleasure to turn this over to Dr. Carolin Fleischmann-Struzek. Carolin, over to you, and then we'll get to some questions right after your talk. Thank you for joining us.
Thank you for the introduction and the invitation to this 4th World Sepsis Congress. I'll talk about the burden of sepsis and long-term consequences after sepsis and infectious diseases. As already mentioned in the introduction in the first session, sepsis is a major public health burden. It is very prevalent among hospital and ICU patients. The acute mortality is still very high, and survivors often face long-term consequences. And above that, approximately 1 out of 3 hospitalized COVID-19 patients is affected by sepsis. So the burden is very high, but we still lack knowledge on the population incidence of sepsis for most countries, particularly for low and middle income countries. Therefore, sepsis was called a hidden public health disaster, and the WHO urged all member states to improve the knowledge on sepsis epidemiology and the database for that area of research. So what do we know about the burden of sepsis? The most comprehensive study on sepsis epidemiology using the framework of the Global Burden of Sepsis study estimated that every year 49 million patients are affected by sepsis worldwide. That is equivalent to 677 cases per 100,000 population. And half of these cases occur in children, mostly in those under 5 years. And just for comparison, the global burden of disease study estimated around 12.2 million stroke cases every year. So sepsis is really a huge public health burden. The global burden of sepsis study estimated that every year around 11 million patients die in relation with sepsis, and this is equivalent to around 20% of global deaths. Many patients that die from or with sepsis have underlying non-communicable diseases or injuries that lead to hospitalization and comprise their immune function. And in the last 30 years, the mortality of sepsis decreased by around 30%, mainly due to the successes in prevention of infectious diseases in low and middle income countries. A recent global burden of disease study estimated the number of sepsis-related deaths a little higher, around 13.7 million deaths each year, and found that around 30% of sepsis-related deaths are caused by 5 selected pathogens, namely Staph aureus, E. coli, Streptococcus pneumoniae, Klebsiella pneumoniae, and Pseudomonas aeruginosa. And 6 million deaths are estimated to be caused by 3 bacterial infectious syndromes, namely lower respiratory tract infections and bloodstream infections, and peritoneal and intra-abdominal infections. And this has, of course, important implications for sepsis prevention, for example, by hygiene or vaccination and the provision of acute care services. Sepsis is not only burdensome in terms of acute mortality, but survivors often suffer from really significant long-term impairments in the physical, cognitive, and psychological domain. Using health claims data of around 23 million insurance holders from a large health insurance in Germany, we found that 3 out of 4 survivors suffer from new impairments in the 12th month after sepsis, and that these impairments are often overlapping. They commonly lead to a new nursing care dependency. 1/3 of survivors without pre-existing nursing care dependency required such care in the 12-month post-sepsis, and 25% of survivors who previously worked were not able to resume work in the first year after their disease. And of course, 12-month mortality was also high. More than 30% of patients died within the 12th month after sepsis. Most common neuroimpairments were neuromuscular, musculoskeletal, and cardiovascular diseases, but also cognitive impairments, fatigue, and also depression, anxiety were really common. Notably, not only survivors with severe or ICU-treated sepsis were affected by these impairments, by new nursing care dependency and 12-month mortality, but also patients without organ dysfunction, without ICU treatment, and even patients without prior impairments had new impairments or were newly dependent on nursing care. And that is similar to what we know from COVID-19, for example, where post-COVID also affects patients after mild diseases not requiring hospital treatment, for example. And that implies that the number of survivors that need structured aftercare or rehabilitation is really high. And there's a really urgent need to develop strategies to care for these patients and to set structures in the healthcare system for their demands. When we talk about the global burden of sepsis, it's also important to keep in mind that the majority of sepsis cases and the majority of sepsis-related mortality occurs in low and middle income countries with sepsis mortality rates up to 10 times higher than in high income countries. And also this burden in low and middle income countries is really high. We still lack data to really understand and monitor sepsis epidemiology in these countries. A recent systematic review and meta-analysis found that sepsis patients in these countries are younger and predominantly HIV infected compared to cohorts from high-income countries, and that sepsis mortality is higher in cohorts with higher proportion of HIV-infected patients. And the most common pathogen isolated in blood cultures was Mycobacterium tuberculosis. That means treating sepsis in low and middle income countries needs or may need other strategies for antibiotic treatment, for example. And therefore, it is important to better understand underlying pathogens, risk groups, and long-term outcomes also in these regions. Another major challenge in assessing sepsis epidemiology is the lack of studies in community-based designs or studies among among survivors to assess long-term outcomes. And the existing studies on sepsis epidemiology are limited in their comparability and validity, given that study designs differ very much among the studies, and also data sources are barely comparable. Furthermore, we lack standardized sepsis definitions and definitions that can be applied in all settings, including resource-restricted settings. Furthermore, there's a lack of standardized and complete recording and also reporting of outcomes in such studies. And many studies in high-income countries rely on administrative data with inherent limitations, as these data are collected for reimbursement rather than for research purposes, and they only mirror the proportion of sepsis cases with diagnosed and coded sepsis that can lead to an underestimation of sepsis cases. In the US, for example, a study found that the incidence of sepsis among hospital patients was 2% using sepsis codes to identify sepsis cases and around 6% using clinical criteria and electronic health records. So that means studies on administrative data only show the tip of the iceberg. So how can we do better? First, there's a need for better or more advocacy and funding for generating evidence in sepsis epidemiology. We need to achieve consensus on a sepsis case definition for sepsis surveillance and epidemiological research that can be applied globally. We need new or advanced databases for sepsis epidemiology research and the better, more accurate ICD coding, and standards for sepsis epidemiology studies and core outcomes to make their outcomes comparable. And all this is needed to reduce the burden of sepsis finally, and to support survivors and patients to bear with their disease. Yeah, thank you very much.
Thank you very much, Carolin. That was outstanding. We're going to just get back on track, and if there's time for questions at the end, I'm going to post one for you, if I may, but I'm going to turn it over to Dr. Syed Ahmed in Bangladesh. Dr. Ahmed, over to you, please.
Yeah, welcome to my presentation. So I will be discussing on the progress on the journey to WSC that has been disrupted by COVID-19 pandemic and how it can be accelerated given the learnings or lessons that we have from the pandemic. I will begin with a little bit with WSC and then move through the main topics like impact of COVID-19 in South Asian countries, what lessons we learned, and how we can do better and look forward. So just start with this very plain and simple definition of WSC. It means that every person can access good quality health services without suffering financial hardship. And then this is the big definition by WHO where it is more detailed out. I think this box, this is known to all of you. This is crystallizes the concept of WSC. So the smaller box is a smaller cube. The blue cube is where we are now, and the bigger cube is where WSC aspires to go. By increasing the population which has not been covered yet, by offering services that hasn't been yet in place, and also to reduce cost sharing and fees so that out-of-pocket expenditure is less. So why WSC? I mean, it has lots of benefits. Just to argue for it, we have these health benefits, health system benefits, economic benefits. It stimulates economic development, reducing poverty and inequality, and a large number of, I think, 100 plus economies were in unitedly declared about the benefits of WSC, how it can better do the development. And there is also political benefits, like extending health coverage is a popular policy and attracts support. And we have seen in many instances that it was the prime mover of some of the politicians to get elected and take leadership, like in what happened in United Kingdom, Thailand, Ghana, Zambia, and many other countries. So how you see? After about 40 years of experience and long deliberation on how services can be reached to the doorsteps of the people, the world now has a consensus that the best way to get services, at least the essential services, at the doorstep of the population by primary health care. So that's the way. And it was declared in Astana, Kazakhstan, on the occasion of 40th anniversary of Alma-Ata. And this PSC is a revamped one where it mainly focuses on primary care and essential public health functions as an integrated package of health services. It empowered people and communities, and also multi-sectoral policy and action. The WSC, this in the global goals for sustainable development, the SDG 3 deals with these health issues, like ensure healthy lives and promote well-being for all at all ages. And especially the target number 3.8 tells about universal health coverage. Achieve universal health coverage, including financial risk protection, access to quality essential healthcare services, medicines, and vaccines for all. So how PSC supports, how can we achieve WSC through PSC and achieve also the health-related SDGs? PSC is a cost-effective way of delivering services that has been shown again and again. It plays a key role in reducing household health expenditure on health because it provides services near to the community and mainly deals with preventive and promotive services. So the cost is much less. It engages empowered people and communities as core developers of services, which also becomes culturally sensitive and increases patient satisfaction, ultimately increasing and improving health outcomes. WSC also focuses on community-based services to tackle social determinants of health, thereby enabling it to reach the vulnerable and disadvantaged population. And there is this multi-sectoral policies and action. There are key components of PSC because we know that the health is not limited to health sector alone. So we have to go beyond health sector, and then and we have to focus on health for all in all other sectors. So that is one of the way how we can achieve WSC. This slide shows the linkages between this primary health care and universal health coverage, keeping SDG 3 at the center, and also its relation to other SDG goals like poverty reduction, education, job, environment, etc. So where does South Asia stand vis-a-vis WSC achievement? If we look at this is pre-COVID data. So the blue ones are 2017 data. And the first one shows coverage of essential health services in South Asia. WSC index score. So WSC, there is a composite index on WSC, and this slide shows that values of those composite index. And we can see that before COVID-19, that is in 2017, the blue one, only Sri Lanka and Maldives and Bhutan, these three countries had achieved something like 62%. WSC index was 62. But for the other countries, it was hovering below 50% mostly, or just above 50%. So we can understand the situation. And if you look on the right, this next graph, we can see that we can understand the reason, because it shows the public health expenditure as percent of GDP in South Asia. And you can see that except Maldives and Sri Lanka, most of these countries were having very low proportion, less than 1% or something of GDP invested in health sector. The current WHO recommendation is something like 2% of GDP must be invested in health. So South Asia confronted COVID-19 very poorly prepared. If you look at this table, you will see that the South Asia invested on average 0.89% of GDP, compared to, say, the world is 5.8%. Even East Asia and Pacific is something like 4.54. And all these health system related indicators, access to basic infrastructure and connectivity, all is a dire example of how poorly prepared was South Asia even before confronting the COVID-19. So COVID-19 laid bare the weaknesses of the health system of South Asia, from poor infrastructure and poor investment. In terms of service, the COVID-19 services suffered greatly. There was acute shortage of human resources for health, who are trained, motivated, and well-resourced. MIS, there was failure to provide right information at right time to the right people for action. There was poor risk communication. There was shortage of medical products and supplies, failure to provide common supplies like masks, gloves, etc. Even not to talk, if we don't talk of PPE, ventilator, etc. Financing allocation was not aligned to need mostly, and there was problems with leadership and governance. So the impacts are obvious: lack of public resources for health and social welfare, including shortage of the health care workforce, constraints on disease surveillance and epidemic response capacity, poor health system resilience, limited testing and contact tracing due to lack of HRS and lab resources. So we could not actually measure properly what was the exact toll of this COVID-19 in terms of morbidity and mortality. And interesting thing was that this time was also the time where there was explosion of corruption and irregularities in health sector. That was very unfortunate. I mean, so this is also reflected in this health security assessment done after the COVID or during the COVID in 2021. We see that the South Asian countries scored very less. between 28.8 in Afghanistan and 42.8 in India, which is below 50 by 50. Most of the last countries in the region scored less than what they scored in 2019. For example, India, Pakistan, and Nepal dropped in 2021 compared to 2019 pre-COVID, although the drop was not that much. So what are the lessons learned? Of course, that strong primary healthcare systems with public health functions like surveillance and emergency preparedness are necessary for attaining WSC and health security. High out-of-pocket expenditure on health and catastrophic health expenditure resulted from managing and treatment of COVID. At least 2% GDP investment in health is required, including in PSC, to overcome this phenomenon. There was poor health system resilience, including COVID-19 response due to shortage of health workforce, infrastructure, and lack of diagnostic facilities. Even there was problems with supply of medical oxygen at the peak of COVID-19 waves. Different 2 or 3 waves are there in this part of the world. And not to tell of the other things like quality of care, use of digital technology that should be improved. That's one of the lessons. So what's the way forward? If you ask me, I will say there are many things I said, there are many studies done, many researches, but I will focus strongly on this thing that fix the PSC. There lies the problem, and the stakes are too high. Sustained investment in PSC is required to turn over the table. At least 2% of GDP to be invested in health sector, and the major proportion for primary healthcare, like 60% or something like that. And investment in PSC should be mainly in human resources for health, especially community health workers who are working at the grassroots and who showed their utility during the peak COVID time, and also areas of structure, quality of care, and equitable service delivery. So we should not forget that no one should be left behind. And all this should be done from public sector financing. And then health security should be inbuilt in the reformed PSC so that it becomes part of the services that is delivered by primary healthcare, and their health workers are trained in these tools of forecasting epidemics and pandemics. And ultimately, only this will help us to be prepared for confronting the next epidemic or pandemic, for that matter. I think I'll finish here. Thank you very much.
Thank you very much, Dr. Ahmed. That was an outstanding list of challenges and solutions that countries around the world can learn from. So thank you so much for that. And now we're going to turn to Dr. Tim Buchman from Emory University. Dr. Buchman, please, over to you.
Good morning, and what a pleasure to be with you today. Let me share my screen with you so we can proceed quickly with the conversation. I'm going to speak today on the health and economic burdens of sepsis through the lens of the United States Medicare system. Let me mention that I'm editor-in-chief of a couple of journals, and my opinions today don't necessarily reflect the official position of those journals or the Society of Critical Care Medicine. Now, just before the pandemic, we released 3 papers from my work with the United States government. These were published in the March 2020 issue of Critical Care Medicine, and they looked at the burdens of sepsis, the trajectories of sepsis, and some forecasting around sepsis. But those data only took us through 2018. Today, I'm going to talk about how those trajectories brought us through the pre-pandemic era all the way up to the COVID pandemic. The data were published in the December 2021 issue of Critical Care Medicine, and I'll be reviewing it here today. Now, Medicare is the largest United States-focused payer. It exceeds the next largest insurer by about a factor of 6. And our purpose is to evaluate the burden of sepsis in this population, to estimate our contemporary costs, and we do this to forecast future costs for the United States, both for Medicare and the larger population. Again, it's a U.S. federal insurance program primarily aimed at the aged, folks over 65 years of age. It includes some younger people with disabilities and people with end-stage renal disease. It doesn't include the poverty program. So it is the U.S. federal health insurance program, as I mentioned, primarily for those age 65, some younger people with disabilities, and and people with end-stage renal disease. It doesn't include the U.S. Medicare costs. It doesn't include U.S. Medicaid, rather. It accounts for about a fifth of U.S. total healthcare costs, and it's, again, more than 6 times the largest private payer. Now, beneficiaries can select fee-for-service. They can also select an HMO plan called Medicare Advantage. But here's the thing. The Medicare population is increasing. As shown in the picture over here, the Medicare population is now over 60 million and is projected to be more than 80 million by the year 2030. The sepsis at-risk population that we're going to be speaking of are those adults 65 or older and those with chronic conditions. Now, if we look at the Medicare sepsis rates just prior to the pandemic, you can see that the number of sepsis admissions was steadily increasing. From the bottom of the slide up is the Medicare Advantage, then the fee-for-service, and then the solid line is total. And you can see that the system was admitting close to 150,000 patients each month. Those are monthly figures who ended up with a sepsis tag on their diagnoses at the time of discharge. Now, even though it looks like this number is steadily increasing, if we move to a 12-month moving average of those sepsis admissions, you can see there is an inflection point somewhere at the end of 2015, the beginning of 2016, and the numbers did indeed appear to level off. Now, one of the questions I'm always asked is the following. If we look on the left at the sepsis inpatient admission rates per total beneficiaries, you can see the steady rise through the end of 2015, beginning 2016, and then the apparent level off. And if this rate of sepsis admissions per million beneficiaries has plateaued, how can the rate of sepsis admissions measured out of all inpatient admissions still be rising? Where's the inflection point? Well, it turns out that the population that we're seeing in hospitals is changing. I've plotted here on 2 axes. On the left in brown, the total number of admissions per month per million enrolled beneficiaries. Those are the non-sepsis admissions in brown, up to 25,000 per million enrolled beneficiaries over time, declining over the 7 or 8 years shown here. In black, the count of the sepsis admissions, now this is shown on the right axis, rising. And what it shows is that we are losing significant numbers of non-sepsis patients. Those elective patients are going elsewhere outside the hospital. The actual fraction of sepsis admissions per million beneficiaries has now plateaued in the range of about 1 out of 400 beneficiaries per month. Now, let's look at the mortality data. These are cumulative data. What you can see here is that the data over 1 week within 1 week of hospital discharge, we were having mortality rates in the range of 25%. All comers at the beginning of 2012, it declined to about 20% by end of 2019. Unfortunately, that mortality would continue to accumulate, and by the end of 6 months, it was nearly double. What I'm showing over on the right are the mortalities broken out by the degree of severity, septic shock at the top, then severe sepsis, where we had our greatest improvements in mortality, the next unspecified sepsis, and then finally the last line, the lowest mortality, is when we knew the organism and we were able to treat the organism. Regardless of the severity of the sepsis, though, mortality would continue to accumulate. This is the lower panel over the first 6 months. Now let's break that down a little bit further. What I've shown you here again in the rust color at the top are sepsis days. That is the mortality cumulative over the first 6 months. The darker darker blue line is the non-sepsis days. Those had significantly lower mortality. But if I break out the mortality after discharge up to 6 months, you can see it's been remarkably stable. Sepsis patients who survived a hospital discharge continue to have a mortality rate that's pretty steady, around 20%, allowing for seasonal variation, while non-sepsis discharges accumulate mortality to about 15%. In other words, and this is a key take-home point, a sepsis discharge will have about a 1/3 higher mortality compared to a non-sepsis discharge over the first 6 months after they leave the hospital. Now, if we break this out by age, that difference falls as we get older. Let's read from the bottom up. In green are the younger patients, 65 to 74 years old. The non-sepsis discharges are shown in the dots. The sepsis discharges are shown in the solid line. And on the right, I show the gap in green at the young age. In yellow is the middle age from 75 to 84. And then at the top, shown in the rust color, is the difference in mortality for a discharge once you get to more than 85 years old. That is, as we get older, we accumulate more illness, and the sepsis admission makes less of a difference. Now let's turn for a moment to cost. Let's take a look at the monthly cost of sepsis during inpatient admissions. And as you can see in the United States for Medicare, that reached as high as $2 billion during the winter of 2017-18. We had hoped that these costs were coming down. You can see this in the lower panel. This is the cost per admission. Unfortunately, by the time we got to 2016, those costs were on the rise. And this is important because we've always understood that Medicare was fiendishly expensive. In 2013, Torrio and Moore thought that the national cost, this includes Medicare and all the other payers, was about $23.7 billion, with Medicare accounting for $14.6 billion. We continued to study this, and we found that the costs were changing based on the character of the patients who were being admitted. That inflection point around 2015, we had a plateauing of the sepsis that was present on admission. And what this led to, here's the level off in the number of cases that were present on admission. We have now see that as that leveled off, the cost per case continued to rise. This allowed us to make a prediction model, and you can see the model versus the actual costs posted here. The model is a pretty good fit for what the actual costs turned out to be. So let's understand what the model is telling us. Again, from the Torrio and Moore study, Medicare was supposed to be costing about $14.6 billion of the $23.7 billion total. if we projected this forward using a conservative number to account for the aging of the United States population, in the 2018 paper, we projected the total inpatient cost for the United States to not be $24 billion, but in fact, $53 billion. But then as we got the additional data leading into the pandemic, the Medicare costs, we were able to refine our projection into the actual cost. Instead of costing $16.5 billion, the actual costs and the projections aligned at about $22.9 billion. And when we move those numbers out to the entire US population, we estimate that the 2019 cost of sepsis was not $24 billion, but in fact, $57.5 billion in the United States for sepsis for 2019. And again, all of these rates and projections made good sense and had good power right up until COVID. So in conclusion, I've shown you that the sepsis inpatient admissions are rising. The rate is almost double that of Medicare beneficiary population growth. The inpatient mortality rates have been decreasing, but sepsis continues to be associated with a 60 to 75% cumulative mortality after 3 years, regardless of its severity. Our cost per admission was declining, but then started to rise again prior to COVID. The total cost burden to society remains unknown, but we continue to underestimate those costs. Thank you for the privilege of the presentation, and I'll stop sharing my screen now.
Thank you very much, Dr. Buchman. Those were sobering figures, and every policymaker in the United States should see them. They're stark, and we'll interrogate some questions after this with everybody if we have time. So thank you so much for that. Our next speaker on universal health coverage for sustainable development is Mr. Roy Small at the United Nations Development Program. Roy, welcome.
Thank you very much, Keith. Great to be with you, and compelling presentation, Timothy. It's an honor for me to be at this conference and to follow some compelling presentations, as I mentioned. Today, I'm going to take a broader look at health and development and overview the power and potential for universal health coverage to help us escape this era of polycrisis where we find ourselves, and help get us back on track to achieve Agenda 2030. So I want to start by taking us back to the year 2015. I'm sure all or most of us are familiar with this, but this is when global leaders and everyday citizens came together and forged a historic plan of action for people, planet, and prosperity. Agenda 2030, or Sustainable Development Goals, features a range of social, economic, and environmental goals that, if achieved, would deliver a better future for all. Now, since its inception, Agenda 2030 has drawn some criticism, a lot of twos, too big, too many priorities, too ambitious, for example. But just for a moment, I think we need to consider what the world is experiencing now, where we have these complex and interwoven risks and threats that are so numerous that we're using words like polycrisis just to describe them. So to me, Agenda 2030 remains as relevant as ever. And the one upside to today's situation is already having the roadmap that we need to chart a different course. So where is universal health coverage in the Sustainable Development Goals, or Agenda 2030? Well, the technical answer is under Goal 3 on health as target 3.8. But perhaps a more accurate answer is everywhere. Because indeed, UHC is both a target unto itself and a means of achieving other goals, both within health and beyond health. And at the same time, other social, economic, and environmental goals contribute to universal health coverage and make it more possible. So how are we doing on this affordable dream of universal health coverage? Well, according to the latest data, the world is way off track. At the same time, we need to recognize that we've made tremendous progress since the year 2000. Coverage has been increased for hundreds of millions of people. Yet, as I mentioned, half the world lacked access to essential services, essential health services before COVID, and still lacks it now. And we know that the pandemic halted or reversed universal health coverage virtually everywhere. And vaccine inequity has shined a spotlight on our failures in universalism and solidarity, and I would add in empathy. And meanwhile, COVID is not over, remained unpredictable, and health systems are facing other major concurrent threats. That includes the chance for another pandemic that may come sooner than we would like to think. So the broader sustainable development landscape is also filled with crisis and uncertainty. So in the wake of the COVID-19 pandemic, for the first time ever, UNDP's Human Development Index value, the combined measure of multidimensional aspects of development, has declined, and for 2 years straight. Now, it can be tempting to blame the pandemic for all of this, and no doubt it has played a massive role. But even before COVID-19, the SDGs were not on track, and 6 of 7 people worldwide felt insecure in rich and poor countries alike. So to me and to UNDP, this means that we need to dig deeper for our explanations and revisit our prevailing development models and approaches. And I think universal health coverage can help us to do that. First, I think we should have learned our lesson of the importance of investing in the SDGs. And now with the SDGs off track, accelerators of progress are in high demand, and UHC certainly fits the bill, as I'll talk about. Second, UHC and global health security are mutually reinforcing. We need to address them together. Countries with universal health coverage have handled COVID-19 better, and vice versa. Some innovative approaches to COVID, or necessitated by COVID, are now being extended to other health challenges in universal health coverage. And third, UHC helps us to reorient our development approaches around healthy societies, One Health approaches, planetary health, something that perhaps does not put gross domestic product at the center. Now, I'm going to cover a few examples of how UHC can contribute to the SDGs, because otherwise I would need the rest of the conference, and I'm sure nobody wants that. But just consider the top example of people being pushed into extreme poverty due to health expenditures. And this makes UHC not just a health measure, but a leading poverty and inequality reduction measure. And the same applies in other domains. So for example, universal health coverage offers a powerful tool to address the human capital loss that we've seen during the pandemic, or the rising gender inequalities that we've seen during the pandemic. Or think about the power of UHC and all that it entails and all the principles behind it to restore trust in global and national systems to deliver at a time when trust is in short supply. Now, to understand the importance of universal health coverage to our economic goals, see the presentation that just preceded me, of course. And I would also say, look at the COVID-19 pandemic. The IMF forecasts that the pandemic will cost the global economy $12.5 trillion through 2024. Now, that's more than the estimated annual cost to finance the SDG agenda in full, numbers that were put out earlier around 2015. That's around $5 to $7 trillion. And it's 500 times as much as some have estimated pandemic prevention measures would have cost us. So universal health coverage, together with pandemic preparedness, I hope can help us to once and for all reframe health as an investment and not a cost. And that includes an investment in the global health workforce, which is 70% women. In focusing us on sustainability, on access and equity, universal health coverage can also accelerate the environmental SDGs. So for example, greening health service delivery through reliable, clean energy solutions and sustainable procurement. That's a big part of the environmental solution. So consider that the health sector accounts for around 5% of greenhouse gas emissions. It's a top emitter of gas emissions. At the same time, clean energy can expand access to previously unreached populations, for example, rural populations. It can ensure uninterrupted health service delivery, moving from lesser reliable energy supplies. And we can't forget the power of prevention. It's been said that the greenest health center is the one that we don't need to build. So I've been focusing on how UHC can advance the SDGs, but it's important to point out that the reverse also applies. And that's because our health, our access to health services, and demand for health services are shaped in large part by underlying social, economic, commercial, and environmental determinants. And if we don't tackle these head on, you see some examples here, UHC cannot be achieved. So we must ensure whole of government and whole of society approaches, which put health and human security at the center. So I'd like to offer a few areas of focus to advance UHC for the SDGs. First, I think we have an opportunity to build on the technological leaps that have been sparked by the pandemic, while also ensuring that this winds up closing equity gaps rather than widening them, recognizing access to these solutions. Second, we must include vulnerable and marginalized groups in all aspects of health policy and programming. That's from the initial design to the rollout, to the monitoring, to the tweaking. Third, we have an opportunity to pair urgent action for UHC with similarly urgent action to achieve the Paris Agreement. WHO has said that the Paris Agreement is fundamentally a public health agreement. And fourth, I think we need to ensure people-centered care that responds to the complex way disease conditions and their risk factors interact. So for example, that includes comorbidities between infectious and non-communicable diseases. And again, COVID-19 was a significant example of these interactions. So I want to close just by commending the Global Sepsis Alliance for putting forth a comprehensive conference that breaks down silos and brings issues and people together. I think this is exactly what we need. And I think getting investments and action right for sepsis can be a pathfinder approach for health, for climate, for UHC, the SDGs broadly. And first and foremost, I think that must include finally ridding global health or development broadly of these so-called under-recognized problems or silent killers or neglected issues that we know about. And tackling sepsis also reinforces other key aspects, for example, the need for multi-sectoral approaches, a focus on prevention and timely treatment, and expanding the research and using the data-driven approaches needed to leave no one behind. And with that, thank you for your time.
Thank you very much, Roy. That was outstanding. You gave a roadmap of solutions that all should listen to, and it's a nice way to integrate the previous outstanding presentations, which fit very well with what you said. Thank you so much. And finally, we have for our next speaker, we have Mr. Rob Yates, who's going to speak on how universal health coverage can climb up the political ladder, so how we get it done. And he's from Chatham House. Rob, welcome, and thank you very much for joining us from the UK. Thank you.
Greetings from Chatham House in London, and thank you so much for having me on this afternoon. And yes, I'd like to talk about the politics of universal health coverage, and I just have a presentation I'd like to share with you about that. So yes, I'm from Chatham House. I'm the director of the Centre for Universal Health at Chatham House. And I want to talk about how UHC can climb up the political agenda, particularly in sort of times of crisis. So just so we're all on the same page, UHC has been well defined already, actually, by previous presenters, but it's all people receiving the quality health services they need without suffering financial hardship. Of course, UHC, before the pandemic, was very much driving the global health agenda. We saw that there was a UNGA resolution back in December 2012. It's got its own UHC day. There was a high-level meeting actually at the UN in 2019 where many heads of government spoke. Of course, it's an SDG target in its own right, as we've been hearing. And many are seeing UHC as one of the best drivers to improve health security. Dr. Tedros at WHO has been saying this frequently. And of course, we've got another high-level meeting coming up on the 21st of September this year. So you can very much see that there is this great interest at a head of state level to promote universal health coverage. And if we think about transitions to universal health coverage, of course, you need to reform all your health systems, the access to medicines and human resources and infrastructure, governance, IT systems. But the one you absolutely must get right is your health financing system, particularly if you're going to have this universal access to services and universal financial protection. Logically, the only way that you can do that is through a predominantly publicly financed health system. And that was something that Gro Brundtland said at the last high-level meeting. If there is one lesson the world has learnt, it is you can only reach UHC through public financing. And I think that these graphs illustrate this transition very well. So WHO have been doing a lot of these graphs recently, showing countries that are spending a lot in terms of their GDP, notice this is public spending. Now, what that means is that people in these quite wealthy countries get good access to health services, but they're also not having to pay high out-of-pocket user fees, which we were hearing from Roy just a moment ago, are a major source of impoverishment. These countries up here, you might say, are sort of starting their UHC journeys. They have low public spending, high private financing, which is associated with poor access to services and high levels of impoverishment. And the journey is really around replacing private voluntary financing with compulsory public financing, but this being an inherently political process. Now, what's also interesting is about these transitions to UHC, that they don't tend to be very smooth, this replacement of private financing by public financing. You get countries making big sort of jumps when they suddenly put a lot of money into their health system to try and improve access and reduce impoverishment. And these big jumps are very much associated with interventions at a head of state level. You know, that if you're suddenly going to put 0.5%, maybe 1% of GDP into your health system, this has got to be a decision taken right at the top of government. And it's unusual for ministers of finance to voluntarily come up with this type of funding. And I'll mention some of these reforms in a moment, but notice Thailand back in 2001, China in the mid-2000s, huge increases in public financing. But there are other countries where that's still to happen. So the big question is, how can we encourage these countries to do what these countries have done and really ramp up their public financing? And I think it's also very important to look at where we are now as global health coming out of COVID and really take stock of the health financing picture. Because I think what COVID showed, and previous speakers have mentioned, was an alarming lack of solidarity between rich and poor countries during the global health crisis. Not only in terms of countries like ours in the UK stockpiling vaccines, but also not funding Act A properly and not facilitating tech transfers. So a lot of developing countries, I think, have felt very left out, very left behind by the Western and rich countries. And we're seeing this having an impact, I think, on sort of other political crises in terms of solidarity around the climate action and maybe even Ukraine conflict as well. That developing countries are saying, why should we care about the crisis that you care about when you didn't support us during COVID-19? This has been exacerbated by huge cuts in aid financing for health, especially here in the UK, where we've seen enormous cuts in aid financing for health. And I think a number of global health agencies are perhaps in denial that the world has changed. That, you know, whereas we ought to be providing additional financing for developing countries. This isn't forthcoming at the moment. But this is the world in which we live at the moment, and I think we need to recognise that increasingly domestic public financing is going to be by far the biggest driver of UHC and also in improving health security. So that really ought to be our focus. How do we encourage countries to increase their domestic public financing? And of course, the key to that is political commitment. How do we get governments to really ramp up their political commitment to their health system? And I think that actually this difficult world in which we live at the moment might actually be the opportunity to do that, because it tends to be crises that can really make or break leaders. And you know, we have definitely seen during the COVID crises that leaders like Donald Trump and Boris Johnson and Bolsonaro in Brazil that manifestly had poor COVID responses have all been voted out of office. And other leaders are recognizing that they really have to sort of take improving health security and UHC very seriously. And, you know, this is the time, I think, to be talking to political leaders about the merits of investing in their health systems. And there's a real history behind great universal health systems coming out of crises, not least here in the UK, where famously we launched our NHS when we were a post-conflict state dependent on US aid back in the 1940s. But France and Japan did the same thing. So you can see UHC reforms coming out of conflict. Likewise, after the Asian financial crisis, Prime Minister Thaksin launched very, very successful UHC reforms. Despite the World Bank saying that the country couldn't afford to do it, he proved them wrong. And, you know, he introduced very, very impressive UHC reforms back in 2002. China is a very interesting example of a country that had previously had a very PHC-led UHC system, but rather neglected it during the 80s and 90s as they liberalized their economy. And as a result, private financing, out-of-pocket financing really dominated at the beginning of the 2000s. But it was the SARS epidemic that really made the Chinese government recognize that hundreds of millions of people weren't really accessing health services, much to their alarm. But it was the political fallout from that the population were very angry that they could no longer get decent healthcare, affordable healthcare, which meant that the Chinese government in effect re-socialized the health financing system with hundreds of billions of dollars of tax financing just in the last 15 or so years. And there are other examples as well of leaders doing this. You know, that this is Governor Jokowi. He was then governor of Jakarta back in 2012, introducing a universal free health system to the population of Jakarta, and it promoting him up the political agenda. All of a sudden, all the parties wanted him to be their presidential candidate. And sure enough, 2 years later, he ran for president on a UHC platform and won that election and has been in power ever since. And you're seeing smart political leaders recognize that now might be the opportunity for them to do likewise and introduce a universal health system. So we have President Ramaphosa in South Africa early on in the pandemic saying that he was going to use the COVID response to prepare for their national health insurance reforms that are passing through Parliament at the moment. So maybe watch South Africa as a country that likewise socializes its health financing system coming out of these crises. And it's interesting to see, of course, the one outlier, the one wealthy country that hasn't adopted this predominantly publicly financed system, the United States, where when President Biden was elected, this tweet was actually taken from just a couple of days after he won the election, saying that he was going to work with Congress to ensure universal health coverage in America. And of course, everyone is aware that he's just announced to run for president again today. So maybe he'll really ramp up his performance in achieving UHC, and this being one of his big platforms for the next election in 2014. So watch this space on the US. But it's in recognition that so many leaders at times of crisis have reached for universal health reforms as a smart policy, not only to improve their health indicators, but to expand their economy, but bring enormous societal benefits and political benefits to them personally, that we at Chatham House have set up a commission for universal health, which is specifically targeting political leaders to encourage them to launch UHC reforms. And our commission is co-chaired by the former president of Tanzania, Jakaya Kikwete, and also the former Prime Minister of New Zealand, Helen Clark. And they are specifically speaking to political leaders about the merits of launching UHC reforms. And this could be one of the best responses to what people are talking about, polycrises, permacrises, that now could be the best time to do this, that COVID-19 has clearly been one of the biggest health crises in over a century. But leaders are now facing multiple crises relating to conflict, energy, food prices, and people are looking to their political leaders for quick wins, particularly around giving them access to decent services and financial protection. So now could be the best time to promote UHC reforms to political leaders. And it's going to be very interesting around the high-level meeting coming up in September to see which countries might really go for it now and catch up with those other countries that launch UHC reforms in the last 10 or 12 years. So if people are interested in following more developments on UHC, I tweet incessantly on this. And that's my Twitter handle there. But thank you very much indeed for listening to my presentation today. Thank you.
Wonderful. Thank you very much, Rob. That is a bit of the cherry on the top in bringing everybody together in terms of how we're going to get from A to B and really arguing that this is really smart politics. I think we have time for a question. So what I'm going to do is just go down from Carolin, down from top to bottom, and ask you a very simple question, which is, what is the one thing that you can share with the attendees that are here today from around the world? What is the one action that they can take to be able to reduce the burden of sepsis? And you could go 1A or 1B if you really feel compelled. So Carolin, please, we'll start with you.
From my point of view, it would be important to foster the potential of prevention, especially by vaccination and hygiene. We saw that pneumococci, for example, cause so many sepsis deaths and can be prevented by vaccines. So that's a potential we should use in the future.
Thank you, Carolin. And it was a powerful point when you spoke about hygiene. Low cost, high impact interventions with vaccination. Syed, please, over to you. What's the one action that you would hope that policymakers and the public can adopt?
Thank you. Thank you. So for me, it is again the PSC, because that's the way how to promote preventive services, including infection prevention and control, and make it part of everyday life of the community that a particular health facilities work. So I think it's again the PSC which should be fixed for sepsis prevention and other preventive activities, preventive health services. Thank you.
Thank you very much, Syed. And we had a number of people from Bangladesh online today, which is wonderful. Tim, over to you. You shared the really truly jaw-dropping costs of $57.5 billion in 2019 that sepsis costs the United States, a country that we know doesn't have universal health coverage. So what's the argument that you would give to the American viewers today? What can they do to advance universal health coverage and reduce sepsis in the United States?
I'll chime in with all the other speakers. We cannot fix sepsis once it's established. It's very hard to mitigate. Prevention is our best, and I would argue, our most important pathway. This involves public awareness campaigns, vaccination, and early mitigation strategies as soon as the host response to infection appears to be losing control. Awareness and prevention are key.
Thank you very much, Tim. Roy, you also brought in another much neglected opportunity, which was really addressing the triple crisis. So universal health coverage was interesting, going back and forth between UHC, health, and the triple planetary crisis. Can you share with us what, from your view, what is some of the top action item that panelists, viewers can take that you want them to do to be able to reduce the burden of sepsis and address that triple planetary crisis?
Yeah, no, exactly. And I think maybe not an action, but a way of thinking, a way of working. I think good things come from working together, and we see what happens when we have fragmented approaches. So I don't think anyone is going to solve this challenge working on their own. And I think coming together, like at this conference, must just be one example of us looking across our sectors, our silos, scanning horizons for integrated solutions. And I think both universal health coverage and Agenda 2030 are just sitting there as proven roadmaps to do that. And I think we need to invest in them. And once we reach that sort of that frame and that way of working, and we invest in it, we can get to this sort of evidence generation and joint planning and coordination and all that's required under that. And of course, it's a political choice as well, but we need to be thinking about it in this broader context of, we need to address a looming debt crisis, or else countries won't be able to invest in UHC. We need to tackle the disproportionate impacts on vulnerable countries of the climate crisis, or else it'll be more difficult for UHC. So we have to think about this all together and work together. Thank you.
Thank you. And I think that it's a very important point to know that what you all shared is actually smart economics. It's not only life-saving, but it's smart economics. And I can do a shout out, frankly, to the work that UNDP, UN Environment Program, UN Biodiversity, the IUCN, WHO, all of you have done in actually showing the health benefits of addressing the triple planetary crisis and how that, and you've all extended that into the issue of sepsis. So thank you. And then Rob, finally to you, we've heard a lot of solutions, but as you definitely pointed out, these are political choices and political decisions. So what do you want the viewers today to do to be able to bridge that gap between what we know and what we need to do to be able to address this challenge?
Sure, and I think it's all about us being much more sort of politically savvy, that we're masters in global health are preaching to the converted, and everyone on here I think is unanimous that the people we need to be persuading are our political leaders. So I think we need to get a lot smarter if we're serious about universal protection against sepsis. I mean, you do need to socialize your health financing system and have a system whereby the healthy, wealthy cross-subsidize the sick and the poor, and that the money is spent very efficiently on preventive services, as we've been hearing. And what we need to do a lot more is presenting the evidence to political leaders, promoting the health benefits, the economic benefits, but not being coy about the political benefits. This is popular, that sort of helping people at times of crisis is a smart thing to do. So I think we need to get a lot more smarter at presenting the political benefits to political leaders.
And I think as you said so powerfully that in a way that this is really smart politics too, and you've laid a challenge for all of us to be. You don't need to be partisan, but we need to be politically engaged. Otherwise, this isn't going to happen. Tim, you have your hand up. Is that?
Yes, I do. I think it's more than socialization of the political leaders. I think we have to make sepsis prevention a social norm for the populace. We often overlook the fact that politicians can create policy and provide funding, but unless the populace is fully engaged, those expenditures will not be as effective as they might be. So it really has to be partially grassroots. We have to find a way of joining our leaders and our followers in this common cause. Over.
Thank you, Tim, very much. And as a former Canadian member of Parliament, I can say that to just say amen to what you just said, because in truth, we know that The public can move the political, and it's up to all of us to engage not only political leaders, but also the public to inform and engage them, and that can be an incredible force for good. On behalf of everybody at the World Sepsis Congress, I'd like to thank all of you, our wonderful speakers who gave powerful presentations, Dr. Carolin Fleischmann-Struzek, Dr. Syed Ahmed, Dr. Tim Buchman, Dr. Roy Small, and Mr. Rob Yates. And for all of you watching, thank you for joining us. And I would say that all of these speakers' presentations are going to be up on the World Sepsis Congress site, so please check it out. They'll be there to see and to share. Also, follow the World Sepsis Congress, follow them on social media, sign the Sepsis Declaration. And from all of you who have joined us, thank you. We've all got our marching orders from these wonderful panelists. We need to get on, bridge the gap between what we know and what we need to do in terms of political action. And if we do, we can all see the incredible benefits that will come to people's lives and also to our beleaguered planet. Thank you for joining us today. Much thanks to all the team who have been putting this together, and have a wonderful day, everybody, and continue to watch the World Sepsis Congress. Thanks so much. Bye-bye, everybody. Thank you so much.